brings me back to one of the questions I have about the study that you did around single side deafness
Mm-hmm.
with the pre and post cochlear implant
Mm-hmm.
and noticing the changes there. You were doing it in children, so it was developing brain
Mm-hmm.
versus work that you've done later on with hearing loss with adults. How important is intervention or changes to a developing brain versus an older
Mm-hmm.
patient or an older subject?
Mm-hmm.
And I imagine there's a lot of different things to consider there, of course,
Right.
because there's something else I want to ask about later around cognition. So how important is that early intervention with that sort of neuroplasticity?
Mm-hmm. That's a really good question. So with children, one of the main factors, and again, just like you said so accurately, there's many significant variables, but one of the main factors is the degree of hearing loss. So if they're born profoundly deaf, we do know that there's what we call a sensitive period where the brain kind of waits for sound to come along. And that seems to be maximum of 3.5 years. Dr. Sharma showed that we have to get sound in to the brain for it to develop like someone with normal hearing. Some researchers are saying a year or less is more optimal if you want the child to perform like a typically hearing peer. Okay. Which is not necessary all the time.
Mhm.
Some people want to use sign language, some people want to use total communication, which are all fabulous. But we've seen if the goal is to be purely oral and to have brain development similar to a typically hearing peer, then sound should be introduced within 3.5 years. And not only introduced, it's not enough to just give a hearing aid or a cochlear implant. It needs to have therapy, speech language therapy, right with it. That
Mhm.
is a must. I have seen a couple children, that's been very, very difficult to see, who I don't know what the situation was, if it was the provider or the family, but they had a device and then there was no therapy with that, and they did not have oral language. So the therapy piece is just as important as the device itself, whatever that might be. If a child has some hearing, they are going to have some input or stimulation of the central nervous system. That's going to vary from child to child, but they're still going to need some type of amplification and speech language therapy. And this is all if the hearing loss is what we call prelingual, before language is learned.
Mhm.
If the hearing loss is postlingual as a child, they are still going to have a lot of neural networks in place. Okay. But they're still going to need speech language therapy, a device as they develop, because auditory cortex continues to develop into your 20s, which is pretty crazy.
Mhm.
So they're still going to need that stimulation or input. For adults who lose their hearing and have these auditory networks hardwired in place, the main factor then becomes how long is their hearing loss in place. That has been shown to be the best predictor of rehabilitation for sound in adults. So there was one review by Giraud who showed that in cochlear implanted adults who acquired hearing loss, that length of time showed how well they would perform post implant.
Very interesting. So it seems like there's a line sort of
Mm-hmm.
between that input side and that processing side,
Mm-hmm.
and there's technology interventions that are part of that input side, But then as you're saying, there's that therapy that's about
Right.
how is that input being processed? And if the
Right.
correct input isn't
Right.
provided, the processing doesn't develop in a way that makes it beneficial to have that
Right.
that technology or that mechanical intervention.
Mm-hmm. Mm-hmm.
Yeah,
Yes,
very
that
interesting.
yeah, that therapy is really key for neuroplasticity to form those networks. We talk a lot about Hebbian learning, and that therapy is what really consolidates those networks together.
Very interesting.